The Kaiser Family Foundation presents health08.org, election news, analysis, and events.
Chip Kahn of the Federation of American Hospitals, thanks for joining us on health08.org.
My pleasure.
The first question I always ask in these interviews is this. I know that you have a fairly broad agenda in terms of healthcare issues. What does the Federation identify as the single most significant problem facing the system?
Without question, for our members who operate hospitals in many states in the country, we have about 20% of the hospitals in the country, my members identify the lack of coverage or insufficient coverage as the major problem they see for the healthcare system. And that's why last year they developed a healthcare coverage plan, which we call the healthcare passport, coverage passport.
Before we get to that, let me ask you, because we always hear about the strain that hospitals are under because of people who are either uninsured or underinsured. Can you give us some real-life experiences that you hear from your members about the kinds of challenges this presents them?
It really comes from two places right now. I mean, one is even before the economy began to deteriorate, they were, even through all the good years, they saw in the emergency room every day, and then obviously every year, more and more uninsured patients. And they have to provide services to those patients. They want to provide services to patients. It's part of their mission. But at the end of the day, something's got to give. Something's got to pay for that. And frankly, they also see a trend that has started really in the last 2 or 3 years, where they see a great deal of change in the health benefits people have who have coverage with much higher deductibles. And whereas some would hope, I think, that those deductibles would lead to more cost-conscious purchasing on the part of patients and consumers, instead, what the hospitals see is that many of these people are willing to come into the hospital. Obviously, the insurance pays for part of the cost, and then the hospital is left with an unpaid deductible. And this is a very large problem because they're receiving services and they have coverage for part of their care, and they're not paying for the other part. So this issue of unpaid, uncompensated care is a growing one. And at the end of the day, someone has to pay for that. And the paying patients, or either those covered by Medicare or those covered by private insurance, are paying that extra cost. And it leads to all kinds of incentives that are problematic and cross-subsidization and increases in everyone's premiums who are paying premiums. And something's got to give here.
Give me some figures on how uncompensated care has grown. Dollar figures, percentage figures over the past 5 or 10 years.
Well, I could say with one particular company, a very large one that I'm familiar with, their uncompensated care numbers have grown by 50% in the last 3 years, and that amounts to billions of dollars. And the actual cost, you know, in the issue of hospitals, you always have this issue of charges versus cost. Their actual cost over their system of many hundreds of hospitals have gone up about $500 million. Those are actual cost for uncompensated care. So that is not a small percentage of the overall cost of uncompensated care in the system.
And so, as you mentioned before, the Federation has developed a plan that it calls Health Coverage Passport. What is it?
Well, we developed this plan a year ago, and my members wanted to do a number of things. One, they wanted to build on the current system. I mean, their belief was that if we change everything too radically, we first have little political likelihood of getting it through the political system, and second, we don't know what the outcome would be.
So the private-public mix.
So they built on the private-public mix. They wanted to achieve universality, and so they looked at the various groupings, income groupings, knowing that many people who are uninsured are connected to employment in some way. There are no mandates on employers. There's an individual mandate, but there's heavy subsidization for everyone below 200% of poverty and some subsidization up to 400% of poverty in our plan. And for the least, those who can least afford it, they would go into the public programs that they may not be eligible for now. And for those who have some income or offered coverage by their employers, they would receive a subsidy to help them pay for their coverage.
Through tax credit or?
Well, we didn't want to use the tax system. We actually, in our plan, assumed that you could structure this through Social Security and make sure that everyone would get, in a sense, a piece of paper or a certificate if they were eligible, and receive a subsidy directly to pay the insurance they might have to buy in a reformed insurance market, or hopefully, if they're offered insurance by their employer and they're low income enough and they turn the insurance down now, they would receive a subsidy for the amount that the employer charges to the employees in their insurance. We actually, our plan would actually end up affecting about 115 million people, more than the 47 million uninsured, because the notion here is that we want to shore up those who are lower income and may be insured now but may not be tomorrow. And we obviously want to help the 47 million. Our impact analysis, we just finished one for 2010, shows that the kind of plan we have that builds on Medicaid, builds on the state child health plan, provides this new subsidy for those who are sort of in between with the ability to either buy into their employer plan or buy into a reformed non-group individual market. We cover all but about 6 or 7 million Americans through our plan, according to an estimate done by Lewin.
And the cost?
Well, there's a big price tag. It's $130 billion in 2010. If you do all the things that we do, and also we assume a benefits package that's equivalent to standard Blue Cross option in the federal employees health plan. So it's a very generous benefit package. So there are obviously a lot of gears in our plan that could be adjusted to lower the cost somewhat. We didn't go through an exercise of trying to raise $130 billion a year, but obviously if we were asked, there's some places you could identify to do it. If you look at the plans that are out there in the presidential race, if they did an estimate for 2010, they would be in the range that we're in. So we're in the sort of given range if you want to get to universality.
Let's suppose for a moment that everything you've just described occurs, is enacted. How does that change the climate for the members of the Federation, for the hospitals? How is it different?
Well, I think I think first the most important thing is to focus on the patients and the medical consumer. I think it gives, for patients and for medical consumers, the comfort and protection of health care coverage. And if the benefits are good enough, and I think this issue of high deductibles is something we're going to have to grapple with, particularly for lower income people. I think for higher income people, having that kind of skin in the game probably will affect at the margin behavior in an appropriate way. But I think we've got to be very careful with lower income people and how we use co-payments. But I think for the consumer, it will help them. It'll give them better access, hopefully better access to more appropriate care. And at the end of the day, that means hospitals can do what hospitals are supposed to do. I mean, hospitals are generally acute care institutions. We're there to take care of people when they get sick, but hopefully they're not coming to us unless sort of everything was done and it's sort of the place of last resort to go from a health standpoint.